So thank you, Fiona, and thanks for the invitation to come here and to share my data and experience with you. And hopefully we can learn from each other, because there's always learning on both sides. And whenever you travel somewhere to teach, you will go back with new ideas yourself as well. So it's a good exchange. I usually start with this picture. Robert drew it for me when he was 13 years old. Balance between food and insulin, and he put a shark in there. And so I asked him, what's the shark doing? And he says, that's how I feel when I fall off the balance. And to me, that's very important information, because I don't have any children with diabetes. My disclosures. Now, the question is often put that, do we really need to care about the HbA1c of children because they don't get complications until they are adults? So from the Swedish registry, Johan Andersen here, he compared 4,000 patients that actually had data from the teenage years and up to 30 years of age, and divided them into 4 groups. So the green is 57, below 57 in the pediatric and the young adult age range. Yellow is 57 as pediatrics, and then 78 when they became adults. The red is improving, so they had a high HbA1c when they were young, and then they improved considerably as young adults. And the blue is high all time. So what can we see? Well, for retinopathy, you would expect those with high HbA1c all over both pediatrics and adult years to have a high rate, and they do, 80% of retinopathy. But it's the same high rate for those that actually improved only when they become adults. So I think that's a very important take-home message. We need to start investing in these young kids as soon after diagnosis as we can. But it's also important to see that having HbA1c below 57 isn't enough, because you can still see a 25%, 30% risk of retinopathy. So we have to do something about it. And earlier this week, Robert's mother actually called me because she was very distressed. He's 36. He now has proliferative retinopathy, and I then looked at his HbA1c over the first 10 years, and it was an average of 60. And he still ends up this way, now risking blindness at the age of 36. And we don't see that reality. Many internists and adult teams, they see this because they come into practice every day. But to us, it's very abstract. It happens after they leave us. So what is it about improving care? Well, you set a standard, you observe the current practice, you compare, and then you implement the change. Very much the PDSA that Justin showed. And for registers, you can extract data like this, the mean HbA1c compared to blood glucose values per day on pumps or 1 to 3 injections per day, and see that it pays off to take more blood glucose samples, and that's useful information. You can also see what happens over time, as we've seen from England here and Wales. This is Denmark, HbA1c coming down, but also severe hypo coming down at the same time. So that contradicts the message from the DCCT that there is a trade-off between HbA1c and severe hypoglycemia. And actually now there are many publications showing that if you go below 7 in HbA1c, that's 53, then you actually can come away often without any severe hypoglycemia. Here we have the Swedish data for the past 5 years, showing a nice decrease from 62 to 57. It looks better here. Now it levels off a little bit. We are, of course, also very eager to see last year's data, but we haven't, they're not official yet. But there's a wide variation between clinics, and here you have all the names of every clinic in Sweden and the percentage of HbA1c below 7.4, which is the ISPAD target. And you can see that it varies from 80 down to 30. So there's really a very wide variation. So what is this? Is this just a bunch of kids running along to see who's the fastest one? Or is it a very serious competition where you get prizes? I think it's very much about sharing your best ideas and really sharing them. And also, when you see all the other names up there, you know whom to ask for advice. When you're at a meeting, you can approach somebody and ask them. But it's very much to us like a cycling team. Someone is in the lead for a couple of years, then another clinic will be taking the lead. And it used to be Linköping. They were the best by far for many years in Sweden. Then Växjö came along, and they traveled all over Sweden to share their ideas. But you can see now other clinics have come up front, and I think that's the way it works. Somebody else is going to come up next year. We also try to visualize this very much, and it's important to realize the power of this annual report. I'm a bit surprised it hasn't hit the news. Anyone can access it, parents can access it, but it hasn't really hit the news. Justin told me he was interviewed in a morning program in television. I think we should try to do that as well. But here again, you have the different clinics. And this shows HbA1c below 52, 52 to 56, 57 to 70, and above 70. So it really characterizes all the clinics in Sweden. And you can find your own name easily, but you can also find your neighbors or somebody very close to you in this situation. And here this clinic at the top has 58% below 52. But you can see that this clinic here actually has only 5% above 70. So there are different measures where you can excel and be best in class. We also show this target here with many sectors, and two of them are about HbA1c. But these are also about what you do and what you enter into the register. So you can get points for other things except HbA1c. So that the purple is higher HbA1c or less than 60% reported. Orange is in line with average or between 60 and 80, and then above 80 is the yellow. So the more dots you have towards the center, of course, is better. And then again, you get all the names of every center. And look at this one. You see, it's quite a good center in that they have a lot of hits inside the target. But actually, they have the highest HbA1c in Sweden. But they're improving. And they're improving by using the register. While we, for example, we have a good situation for HbA1c, but we need to improve when it comes to using the registry to fill it in. Other countries like Norway have the same principle of displaying all the names here. Mean HbA1c and proportion below 7.5. Now, I was a bit disappointed when I read your report, I have to say, that was last year, because I couldn't find any individual names. In the previous year, at least they were listed in tables, and that's how I made one of my figures. But here, you only have the districts. And the mean is not, there's not very much variation here because you put everyone together in a big basket. And so the lowest are 68.9, but the highest are 72.9. And there's not much to learn from here, I would say, because you dilute the information by just stacking them together. And it's the same with pumps. So it's between 21.8 and 9.9. But of course, there must be clinics that are above 50. And maybe there are some that are down to 0. And these need to be identified, and you need to know whom to address it for different questions. The funnel plots might be very good from a statistical point of view. And you showed us that you get an orange dot for your own center. Well, if this was our center, we'd want to go here because this is the same size of clinic, and how did they do it? I wouldn't know because I don't know the name of the clinic. So I think you're missing out on very powerful issues of the data that you collect, is how to display it, how to challenge people to go to look for their friends. How did you do this? Lena Hanberger is a nurse in Sweden who did her dissertation on registers, and she wanted to find out why are things different in different centers. So she looked at 5 centers with the lowest mean HbA1c, 5 centers with the highest, and then 5 centers that had a decrease over some years. So here you have the high centers around 70, the low centers around 60, and the decreasing centers here. What was the result? Well, she found that these centers that performed better had a higher insulin dose and also higher compliance to the guidelines of HbA1c levels, what to do if they were above target. They were larger in size, larger team size, but, and this is very interesting, they had fewer years of diabetes experience, the members of the team. And it's quite a difference, 12 versus 8 years in diabetes service. And also less diabetes-specific education. So how is that? And then you have to go to your own team, perhaps, and have a look at it. And I felt that this addressed me very much, because I was traveling the world, but I was not really paying too much attention to our own clinic. And often young people can have a lot of enthusiasm, and that helps when dealing with families. And older members might say, well, we've tried that, it doesn't work. So I think this is a big challenge to take up, that you can do a lot of things with very soft data, so to say, just by youthful enthusiasm, perhaps, young people entering the team. And then the target was lower, and we'll know that from many papers that a target makes quite a difference. But also how things were expressed. Physical activity is a part of the treatment, versus diabetes is not an obstacle to physical activity. Dextrose is usually enough for hyperglycemia, versus you can treat it with dextrose or food, depending on the situation. Same message from the whole team, versus a lack of cooperation within the team. So these had a clear message, were more involved, had a more positive attitude, lower target, and they had themselves the perception of a well-functioning team, while the others were more vague, less strict. They needed a framework, and they had themselves a perception of a not functioning team. Now, going back to national results, we can see that HbA1c is actually much lower in the preschool age group. And then when it comes to teenagers, it's higher, but we're improving all over the range. Severe hypoketoacidosis, retinopathy, and microalbuminuria data. Now, is this part of the explanation that we have lower HbA1c in young children? Well, this is a Japanese publication with, in 2008, 800 patients, and you can see that HbA1c has improved. So this is 95, 2000, 2008. But actually, they have higher HbA1c in the young children. So that might be one of the explanations for the international comparison that Justin showed, and we're going to look more closely into this issue. You can see here then that the youngsters actually have a lot more pumps in Sweden. So the national recommendation now is that any preschooler should go on a pump from diagnosis. So maybe that is part of the explanation why they have a lower HbA1c. Well, the pump use differs quite a lot in Sweden, from around 15 up to 80%. So why is that? And does it matter for HbA1c? Well, a scatter plot here shows no difference. We're now starting to collect data on CGM, and there is some evidence that CGM makes a bigger difference for HbA1c. And we're approaching, in many clinics, 70-80% use of different types of sensors. And that could, I think, contribute to a decrease in HbA1c. But this was done, the slide that Justin showed you, I mean, CGM on a larger scale was introduced after 2014. So why do we have 3 lines here? Well, here HbA1c is kind of stable, and then the people behind the registry thought that we have to do something about it. So they constructed a quality improvement collaborative, IQ1, and that was about 30% of the teams in Sweden, and then IQ2 started a year later with, again, around 30% of the clinics. And you can see that once you go into the IQ project, your HbA1c starts to decrease. But these are the non-participants, and you can see that later on, they also decrease. And that's what is called the spatial spillover effect. So how come? Well, any conference you went to, you would, because you would know from the data which centers performed well. You would go and ask them, what ideas do you have? How do you do it? And then people would take those on board again. And you can see that the effect here is pretty good. Now, there's been a third round, so around 90% of the teams actually have gone through this procedure. This was our own project, and the way you do it is that we sat down and through the PDSA and other methods, fishbone analysis and so on, we created our own projects. And the project at my clinic was to keep HbA1c below 52 for the first 18 months. And one of the nurses thought that was very unfair because it was directed so much at the new onset. And she wanted spin-off effects for the other kids at our clinic as well. And I think we did get that along the road. And of course, we were very pleased to see that after 12 months, there was quite a difference between the control group, which was taken before we started with the project, and then during the 18 months project. And even after 24 months, there's quite a difference. Although it's not statistically significant, it's very clinically significant. And here, looking at the individual patients with the control group with the diagnosis in 2010. And here is the one at 12 to 13, and this is the ISPAD target of 7.5, and you can see clearly that most of the children are below, but here is a difficult teenager who had a hard time with her diabetes. But she is coming down below 60 now. So what did we do? Was this rocket science, or what were the ideas? Well, already from the onset, or from the control group, we had MDI from the onset. We used injection aids in preschoolers. All preschoolers got a pump. We had blood ketone meters available for everyone, and there was CGM access when needed. So what we did was to begin with carb counting from day one. Previously, we had taught it once the family were interested after maybe 6 months or 1 year. We switched to iPort, which is just another product. But I think the main thing was very simple. Keep track of mean glucose in your meter and register it, and tell us when it goes above 8. And this simple measure actually created a lot of feedback from the patients, and they took on board a goal that they could actually encompass. Because HbA1c is a bit abstract, you never know what it's going to be, but they could track the mean blood glucose. And although there's a wide individual variation, it proved to be very useful. I see a lot of you are taking notes. I guess we can circulate this as a PDF. We also had a project where parents would help other parents at the onset, and we tried to target the fathers to become more involved in diabetes care. So this is a sample over 7 days, 15, 14 days, and 30 days of the blood glucose and the mean values here. And here you can see that this boy had a cold with fever, so his glucose values went up. But then, of course, 1 week goes down first, and then 2 weeks, and then 4 weeks is going to come down. And this way they can keep track on what's going on. And it's not going to be so much of a surprise when they come to us, what is HbA1c going to be? So is this part of the explanation for the difference between countries? Well, there are some published data. This is from Yale, showing an idea of around 3 months, and then HbA1c slowly goes up. And this is from the DPV registry, showing the same thing. The nadir is at 3 months, and then it slowly increases. So I compared these huge units with more than 1,000 patients to our 17 patients, which is, of course, not a fair comparison. But what you can see that actually we managed to get them lower down here with this project. And the nadir for both groups actually is at 6 months. And we keep them at a lower level. So maybe this is where we start, with a lower level from onset. And there are a lot of data showing that the HbA1c tracking, that what you get after diagnosis is what you'll continue with. And we're going to look into this with the international comparison as well to see if that is part of the explanation. Now we have access to online statistics with our registry. It's an internet registry, so all data is entered online, and it's done immediately afterward, after each visit. So I can always access a comparison for the past year. And this is the whole country, and here we have our individual results. And we can see that we're doing better in the young age group, not so much in the teenagers as we are here up to the pre-pubertal children. We also get an ROC curve showing HbA1c compared to the country. And if you look at the ISPAD target of 7.5, we can actually access that in 70% of our patients, while the country mean is 50%. If you take the new NICE guidelines here, we have about 40% of patients below that, while the national average is 25%. And this can be done every day. I have to say, I don't think all centers are aware of it and use it, but it's a very practical tool to figure out where to put your resources. And you can see that for the high alert is 8.6 or 70 millimolars. We're doing just about the same as the rest of the country. And also if you remember the slide from Japan, they had very much the same average in teenagers. We get the statistics for pumps versus no pumps, and there is not much difference here. We have about 70% pumps. Now, SWEET started out as a European entity to create centers of reference with more than 150 patients. And ISPAD started a collaboration with SWEET to get centers below 150 patients to enter as well. And the first 40 centers were able to join for free. So this is an invitation to you all here. If you're interested in joining the SWEET registry, you can address me by an email or send it to Justin or Holly, and they can direct it to me, because we're very glad to have members from all over Europe and also all over the world. As you can see here, that it's concentrated in Europe, but actually every continent is represented. So what do you get? Well, you get an output of HbA1c among all the centers, but the only center that is named is your own here. Now, we hope this is going to change, so at least in-house, the people who go to the meeting in March are going to see all the names. But it's a process, and we hope that it's going to be open, because it gives so much more information. So this was, of course, very nice to see, but this was not so nice. Our center, and this is percentage with patients with BMI above the 85th percentile, then we're at the far right. And although this is collected in Swedish registry, it's not displayed in the annual report, so I didn't know. And this is the beauty of being part of the registry. But of course, I would want to know, how are these doing it? But unless their names are there, I don't know whom to ask. And this is from your own registry, showing that there is an obesity problem among children with diabetes. Now, for the project that we did, when comparing the BMI, it went up to somewhere around +1, but there wasn't so much of a difference between the groups, although we had different HbA1cs. So maybe we're doing things the right way. These are just the names of the centers that have shown an interest through this ISPAD initiative for smaller clinics and also some of the larger clinics around the world. But there is no UK in here. So we'd love to have more UK centers involved. We often use this thermometer for HbA1c to explain to patients what the connection is between HbA1c and blood glucose. Here, so this is the target for adults, 52, and 58 is the ISPAD target then. Now NICE came out with 6.5, and we were shocked, 48. And everybody had the same immediate reaction. It's impossible. We cannot do that. Think about the stress for the families, etc. We've discussed this at many national meetings, and we adopted the target. And in the end, without any objections. So how come? Well, I read what you wrote, and you wrote this. Explain to children and young people with type 1 diabetes and their family members or carers that an HbA1c level of 48 or lower is ideal to minimize the risk of long-term complications. This is not a target, this is a fact. And would you want to withhold this fact from families? And I heard that it was actually a parent in your group when you discussed this within NICE that was driving when she realized that this is a fact rather than a target. And I think that's very good news, because we want the parents to be driving this. And if you can get it along to the parents, they will do it on their own. Some teams then say, no, HbA1c is too low. You cannot go so low. But if there is no severe hypoglycemia, I don't think we should restrict them in that way. And we know from many studies that the target needs to be a little bit in front of you, so we don't expect everybody to go to 48. But a lot of families can do that. So my personal target, 48, yes. And I have to say that no family has objected to this when I put the fact of 48 to them. And they've all said, okay, we should strive for that. So the big discussion, I think, is going to be within ISPAD, because we're putting out new versions of the guidelines in 2018. And I'm sure it's going to be below 58. But the question is, will they take up the challenge from NICE? Will we take up the challenge from NICE? In my opinion, yes. But we'll see what happens. And I'm not showing the data here, but there are many centers around the world with very limited resources. They use donated insulin, donated strips, but their HbA1c is not, it's very much in the range of what other countries have around the world. So it's not all about money and resources. We're not the only ones. This is from the drug industries showing access to medicine in developing countries. And you can see they're all named, how well they perform on different scales. And also donations and philanthropic activities, they are named. And I think that's the only way forward. And I would urge you to really use the power of displaying the results. Maybe you could do like in sports. You have different leagues. The top league, the middle league, and the bottom league. And then you would get down to manageable numbers of centers. Like we have 40 now. Maybe you could have 50 in each league. And people would want to qualify for the higher league, of course. And whatever we do with this, we find positive response. And of course, there were some quarters, like you said, Justin, at the beginning, this doesn't really show what we have. It's just this. Our laboratory method doesn't show the correct HbA1c, etc. This has all vanished, and we see it as a healthy competition between friends, and we learn from each other. So I'd like to acknowledge my diabetes team here, and I hope I've given you some thoughts to carry home, and I'd very much like for you to join us in Austria for the next meeting. Thank you very much.
So my question is, should we be looking at HbA1c adjusted blood glucose variability?
Yes, definitely. And I don't know that for Robert, of course, because we didn't collect that data. Now it's part of our report. We collect that since a couple of years at every visit. And from this year, we now also collect it in the central registry. So we hope to be able to show some data on that. But I think it's, and also variation in HbA1c, because that has been proven to be even more deleterious, which is a bit strange. But if you sometimes are on low, sometimes are on high, like if you have an eating disorder, that's really scary how much of retinopathy you get from that.
Thank you. Can I ask how you collect and present the glucose variability? Is it just with a simple standard deviation? Because we can all collect that on DiaSend.
Yes, it's the standard deviation.
Yes, thank you.
You had a question? There's one over here.
Just a very practical question. There was a study where you were aiming for the HbA1c in the first 18 months to be below 52. Mm-hmm. You were recommending the iPort or the Insufflon for the under 10s. What was your experience in terms of the difference with that compared to not using a subcutaneous cannula?
I think what we experience is that professionals and parents want their kid to be brave. And so if you have to take injections, you don't ask any questions. And if the team doesn't ask you at the visits, you won't ever tell them that it actually does hurt. We did a controlled study with Insufflon that was with regular injections, and there was a huge difference in reported pain from parents, from children, and from nurses. So that was really compelling evidence. And in our clinical practice, we find that it's less of a problem with injections, and they can actually take more injections, take injections for snacks, etc. They can take 1 or 2 injections if they eat dessert and so on. So to us, it has been a good tool, but we used it even before this.
Thank you.